I don't have, I know that you've had a lot of information thrown at you for a long period of time. So I want to try to tailor the discussion into those areas where you probably have more interest. So some of the slides I've got, I'm just going to whip through. If you want to look at something in more depth, please let me know. Please stop me at any time, or put your hand up, or stand up, or just yell out within reason. And so I'm happy to have a more interactive talk, because I don't know what you've already looked at and what you're interested in focusing on. So this is a bit more of a political discussion. I hope you're wearing your hip waders and gumboots, because it does get a bit messy, as you probably are aware by now. And the question, I guess, that we can start with is, well, why is it that things don't happen, as opposed to what should we do? Now, in 2013, so about 10 years ago, some of my health policy colleagues published a book called Paradigm Freeze. So why is it so difficult to achieve health reform in various Canadian provinces? It's worth the read. I'm not going to give you a blow-by-blow account, but again, the observation was that despite the ideas that we have, things just didn't tend to get done. So where I suppose the key insight that I want you to have in the back of your head at all times is that you know, systems are an interactive set of cogs, and every time you want to move the system away from the status quo, chances are there's going to be winners and there's going to be losers. Right now, if everybody is on side, it probably will have happened already, right? Because there's no resistance. But in a way, you have to think of this in Newtonian physics, in terms of Newtonian physics, right? For every action, there is an equal and opposite reaction. So if you want to change something, it's useful to try to identify the winners and the losers, because I can tell you, if people perceive themselves to be losers, they're going to dig their heels in, and the more powerful they are, the more their heels are going to be dug in and less is going to be done, right? So you always have to keep that in the back of your mind. And in addition to that, so the interest, the constellation of interest, who wins, who loses, absolutely critical to understand. And as you know, even in Nova Scotia itself, there are dozens of different identifiable interests, right? And sometimes they're out of the healthcare system. And you have to think about, you know, how people outside the healthcare system can also put the brakes on. So that's the first thing. Identify the interests, figure out who wins and who loses in each suggestion for change. And the other point I want you to keep in mind is that, and this is especially true when you're looking at comparative analysis of what happens in other provinces, right? Why is one province able to achieve something but not another province? And you have to also understand the terrain, right? What the structures and the institutions are going to be different, and sometimes the institutional framework is going to facilitate change, and in other instances, like even the way things are structured or organized, or maybe the laws that we have, because the laws governing health regulation or health insurance are quite different in each province, and I've read each one of them, and I can tell you they're very different. So the terrain, the legislation may facilitate or accommodate certain changes in some jurisdictions and not in other jurisdictions. Yes, please.
So who might put the brakes on? Right now it seems to be the window of opportunity in healthcare, because there's money here, and it's a window of opportunity. So who might put the brakes on that, or who might be pulling?
Right. Who's going to dig in their heels?
Yes.
I'm going to be looking at some key players in just a sec, but I just have to say as well, it depends exactly what you're suggesting, right? Because some interests can say, oh yeah, go ahead with that, but they'd be very wary about a different kind of suggestion, and another group of interests might have the opposite view. So it really depends on the specific suggestion. Whose toes are you stepping on, right? And that's the thing to think about. So when you're thinking about reform, again, just identify the terrain that you're working in and see how it can either facilitate or obstruct change, identify the potential losers. Now, when you know who might be putting up resistance, then what do you do? We're going to have to get them on board. How do you do it? Well, in technical terms, right, there's sticks and there's carrots. And there's advantages and disadvantages of each, right? Because, you know, carrots can be very expensive, especially in healthcare, right? So you can throw money at something, get people on board, say, yeah, we'll pay you a lot more. BC primary healthcare reforms come to mind here. Or you can, you know, if a group is really resisting a change, what do? You compromise. You say, well, okay, you know, we'll pull back and we'll meet you halfway, 50-50. And look at, oh, okay, yeah, we can say. So you get change, but you don't achieve what you wanted to set up, what you had set up to achieve, right? So you have to be prepared that in order to get progress, you only go 2 steps forward instead of 10, right? And it's compromise, it's how politics work. And then when people say, well, how come this reform didn't happen the way you said it would happen? That's why, right? So, but that's how politics works. And again, you can use sticks, and lots of examples from this province. And what happens when you use sticks? People get pretty stroppy. And, you know, if you want people on board, sticks are not a good way to do it. It's cheap in the short term, but not necessarily in the long term. Okay. Now, I think that you've already covered this. And I guess the only point I really want to make here is that when you look at the institutional landscape, including the legislation, Canadian healthcare across the board is based on an armature that was established mid-century, 20th century, right? And we want laws to be clear and concrete, and because we don't want laws floating around. But the problem is that when the system changed, you still have the laws. So, you know, the institutional structures that we're using are based on how healthcare was organized in the 1950s or 60s. And as we know, healthcare is a completely different beast now. I'm pretty sure that you've looked at this already, right? The very nature of healthcare is so different. And specifically, we have a lot more chronic care issues than acute care. There's more things we can do. There's more drugs, there's more diagnosis, but when we have them, we have to monitor them, right? And the more drugs you have, the more chances there are that they're going to work at cross purposes, or they're going to have iatrogenic effects, or they're going to have negative side effects, and then you have to keep your eye open for that. So the more opportunities you have, the more labor power it takes GPs or other primary care providers to try to monitor it, right? So healthcare is different from what it was when we set up the healthcare system. Demographic profile, of course, of people is different, and of course the healthcare workforce is different, and I'll be looking at that as well. Okay, so now I know that you're going to be looking at specific suggestions, and that's what you probably should be doing if you want real change. I mean, I always think of the Economist article. I was talking about how do we improve the economy of Nigeria. And the answer was, well, just get rid of corruption, right? And you know, if you start, yeah, simple idea, right? But you know, if you can't operationalize it, then it's pretty useless. But at this point, I do want you to just step back for a second, understand the larger context, to look at the politics, and if you're really focusing on the political context of healthcare, you're just looking at healthcare, right? But healthcare itself, for the policymakers, for those people who are actually in charge of putting these policies into place, the people who make the policies at the higher level have to balance healthcare with a whole number of other things, right? So you might think that healthcare is important, especially this corner of healthcare, but the government, the executive making policy has all these other things on the table, and healthcare is just, it's an important aspect, but it's just one aspect, right? A lot of people pushing to get stuff done in housing, and housing is expensive right now. Well, how are you going to balance that out with healthcare? And also, you know, as you know quite well, healthcare is very costly. So you say, oh, we should do this. It's going to cost this, but you know, it's worth it. Oh, we want to do this, and yes, it's going to cost us this, but it's worth it. It's a good investment. That's great. But What are the priorities? Now, did anybody read the Chronicle Herald this morning before coming here? Okay. Did you see Don Mills' comment?
Yeah, I just mentioned it. Oh my gosh.
Zero growth. We've got to get back to zero growth. And so if you go back, and naming no names, but a previous political administration, their raison d'etre was deficit management and debt reduction, right? And they took on the public sector. And as you know, healthcare is in the public sector. So the priority there was largely debt reduction and deficit management, or vice versa. And I'm not going to argue with that. It's a good thing. It'd be great to have less debt and no deficit, obviously. But how are you going to square that with healthcare? And remember too, when you talk about the political context, that it's not just the government making decisions. We chose, as Nova Scotians, we chose that government. And I think at some point in time, the NDP at the same time were running in one of the elections, and they were saying, well, we really have to reform long-term care because it's outdated, it's dangerous, we need more beds, we need more buildings. And they got blown out of the water. People were not interested, right? So it's not just governments making decisions. Governments are themselves, they will follow where the public wants to go. And if the public mood is for debt reduction, that's going to take priority over healthcare. Now, I'm happy to say that since COVID tables have turned, right, we have realized that we can deal with debt without getting struck by a bolt of lightning, right? So this whole thing about we have to balance the budget is not as pressing as it was 10 years ago. But if you look at the long history of health policy, both federally and provincially, there is what I've called a boom-bust cycle, right? You can go back to, you can follow the pattern where, oh, we don't have enough doctors. We don't have enough doctors. Oh, let's get more doctors. We've got more doctors out there. Oh, they're costing us so much. We can't afford health care. And what was, there was a recommendation in 93 maybe, there was a major report written, and essentially, amongst other things, one of the recommendations was, well, stop throwing so many doctors out there if you want to bring the cost down, right? So, keep in mind that there's this whole temporal, so in the first place, there's a competition at the policy-making table with healthcare and other things, and there are other things out there. And also, over time, it's going to shift. And right now, healthcare is in the ascendancy, and that's great. Make the most of it, right? While the sun is shining, make that hay, but expect that when the bills come in, the political sensibility is going to shift again, right? So there's an option. Now there's an opportunity, but it won't last. And the other thing is, of course, we can't talk about healthcare in Canada without talking about federalism, right? And another actor is the federal government. But because we have a federal structure, it means that when policy is made, there's a lot of maneuvering regarding cost shifting and blame shifting, right? So this is too expensive. Can we get the federal government to pay for it, right? And of course the federal government is going, no, the provinces are responsible for this. Oh, things aren't happening to us because the federal government is paying it. So there's a lot of that going on, politics, right? But at the same time, you have to take into account that whatever decisions you make have to be seen within the context of federal relationships, for better or for worse. So we can get into that until the cows come home. I'm happy to do that. Okay, so some of the players here. And here we get into some of the governance issues. So who makes, and if you've covered this, please just sort of look bored, look at your watch so I know that you know this already. So my students do very well. The Department of Health and Wellness is a key player here, but this is in theory, all right, this is how it's supposed to work according to public administration theory, and we can revisit that as well. So the Department of Health, I'd like to walk around, but I don't know if the mic would pick up my voice, so I might just stay here even though, but I might break free at some point and just try when I get worked up. The Department of Health and Wellness is the key player in terms of overarching policy. So in theory, we talk about Is this mic on?
You might.
Here.
There's another mic. Yeah.
All right. So this is just symbolic mic?
I think it's kind of
Fake.
Gotcha, okay.
This will project to the room.
Okay, now I feel like Oprah. Sorry, Oprah. So the Department of Health and Wellness now is in charge of broad policy making, right? And the distinction is that is between steering and rowing. So the department sets the direction, and the Nova Scotia Health Authority, apparently now we just say Nova Scotia Health, is in charge of the day-to-day operationalization. The example I've used here is physician recruitment. So in theory, the province will determine what is needed overall, and the health authority will try to figure out ways of recruiting according to the policies that are the priorities set by health and wellness. Now, between these two, there's a lot of ink spilt about the governance structure of Nova Scotia, and if you wanted a nap, I could probably go into this at length, but I think I should avoid it otherwise. As you know, there was a huge overhaul around 2015, and we used to have a number of regional health authorities, and of course before that we had even more regional health authorities, so that shifts quite a lot. And the relationship between these two is not as cut and dried as the theory would have you believe. And again, I don't know if anybody has been reading the national newspapers about the Alberta healthcare system. Anybody? Yeah, just have a look if you want to see how this actually works. So you have Alberta Health essentially making a lot of what some people would think of as, you know, day-to-day decisions in terms of hiring and firing mid-level officials. And one could probably suggest that the same happens in Nova Scotia. So, you know, if the government thinks that they should step in to cause something to happen, they will, regardless of what the formal rationale for the structure is. So these are the two key players, but again, broad overarching theory, overarching priorities, and the day-to-day running of the system. So another key player, of course, Doctors Nova Scotia, and yeah, I put union in quotation marks. It's not technically or legally a union, but that's what it is. It's a professional, it represents the professional and political interests of physicians. And in the past, yeah, I think physicians, if you go back several decades, so in the 1980s, physicians were a very strong political force in Nova Scotia. In fact, next to Ontario, Nova Scotia had the best paid physicians in Canada. And of course, what happened is that we elected doctors as premiers and as health ministers, and they sort of said, yeah, we know what's happening here. And they were more able to stand up to the interests, and that's, of course, when a lot of the reform began to happen, for better or for worse. But so Doctors Nova Scotia is a professional interest of the doctors, of the physicians. Then you have the colleges. You have the College of Physicians and Surgeons, and you have individual colleges for individual medical professions. But they're the regulatory structure, and they have power insofar as they can determine exactly what is required for somebody to be or to not be a physician. Yes?
And I'm not sure what happened with this, but wasn't there something out about 2 to 3 months ago where Kingston was looking at legislating away some of the power from the college? And if so, what impact would that have?
All right, yes, you're absolutely right. I can't remember exactly what the changes are, but there is a tension because the medical profession is called a self-regulating profession. It looks after itself, but the question then becomes, well, exactly what powers does it have? Not set up through legislation, but legislation, as you know, can be a bit gray, can be a bit blurry, so there are areas where it's not clear how much authority they have in specific areas and how much ability the government has to be able to push them in a different direction. Anytime you talk about the professional stature of physicians, generally the politicians defer to the regulatory authority, right? Should physicians be able to do this, that, or the other? Well, we'll leave it up to the regulatory authority, but if they wanted to, the province could in fact push back. They can also change legislation, right? So the number of ways of doing it. But all of these are different loci of power. And there's, of course, a few more. I mentioned the federal government, but departments of finance. And departments of finance are in control. We think that policy happens, health policy happens in health departments, sort of, but nothing will happen without the Department of Finance giving it the thumbs up and screening it and looking at it and putting it through the mill and putting it up, looking through it. And so really a lot of policy making depends upon getting the support of the Department of Finance. Federal government, as I said, also important. And then you've got other healthcare professionals. I don't want to leave the nurses and all the other health professions out because they play into the mix as well. Now, having said that, so healthcare, just one piece of the puzzle for policymakers who have other things on their agenda. And primary care, of course, is just one part of the healthcare system, right? We have acute care, obviously, people not getting their operations in time. Emergency care, people sitting in an ambulance bay for 7 hours. Well, you know, that's going to draw attention away. There's all these different parts of the healthcare system. Primary care, again, just one part that has to compete with all these other aspects. Options for reform. There have been a number of different questions. Here's some stats. If you've got the slides, you can look through it at your own leisure. Generally, Nova Scotia has fared quite well when it comes to the actual number of physicians, and it might not feel like it. A lot has to do with distribution and what these physicians are doing. But family physicians, we have a better ratio than the rest of Canada. We used to be, I think, number one. We used to have the best ratio, and now we're dropping. And then this has to be seen within the Canadian context. I've put some other figures below. Some countries like Australia and Germany have almost double the number of physicians that we do, but other countries have less, such as Japan. So what is the relationship between access to care and the number of physicians? It's not as clear as we might think. Do we pay our GPs enough? And again, this is worth looking at. This is a fairly recent stat. And even though Nova Scotia has a slightly smaller health budget relative to its overall budget for various reasons, the physician services budget was, I think, the highest of all the provinces. And there's not all provinces are here, but of the health budget, we spend an awful lot on physician services, just FYI, right? And again, looking at it as cost per person, given what we can afford. Nova Scotia's not doing that bad, right? So it's not as if we're not putting enough money into physician services. Regarding family physicians, this especially, some of my marks are not coming up in this, but if you look in the right-hand column, if this is what physicians make, then you can go down the column and compare what other if GPs are making this amount, what's at the top, then what other physician categories are making are spelled out. So, you know, if you look at all the kids going into, the young people going into med school these days, would they want to choose family medicine? Well, you know, just throw them that. So, and this becomes important. You may have looked at this already, but, you know, look at radiologists, and there's a lot of tension between radiologists, according to family physicians, they just stroll in, they, you know, look at a few x-rays and they stroll out again, they go home. And the family physicians have to build a clinic, they have to, you know, pay for staff, they have to invest a lot of their income in the infrastructure where ophthalmologists and radiologists, no, I'm just, for, if anybody knows a radiologist or not, I'm just giving the crude argument here. It's a lot more complicated than that. But there is a sense that family physicians are getting the short end of the stick, so why go into family medicine? How much do we pay family practitioners compared to other provinces? Again, we don't do that bad. Obviously, the Maritime provinces or the Atlantic provinces don't pay as much. It's interesting looking at BC here, right? So BC also generally is a little bit lower, and I think, put my reading glasses on. So we're slightly better than BC. I think these figures vary up and down as agreements are negotiated. There was a question, yeah.
Yeah, could you go back to the other slide for a quick second?
Sure, this one?
Yeah.
Okay.
So when you look at those figures, is there any sense that there might be kind of look at, are we paying some of these specialties a little bit too much? Because I do have a friend who's in his residency for radiology, and he has admitted that one of the reasons why radiologists were paid more was because back in the day, that was a very dangerous thing to do.
And ophthalmology, right? Ophthalmology used to have to, put somebody out and then get in there with your scalpel, and now it's just this machine and this laser beam and tick, 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 and they're gone. But once you pay a profession a certain amount, how are you going to claw it back, right? And that's political right there. So I would not want to articulate this, as I have bad eyesight. I depend upon ophthalmologists. but the argument more is, do we have to look at shoring up family medicine rather than bringing the other professions down, right? So, but it's highly political, even within the medical profession itself. Absolutely, that's a really good insight. Okay, so there's how much we pay. That's one question, and do we pay them the right way? Oh, my circle's not coming. So if you look at the far right-hand side here, there are different payment models. I don't know whether you've covered that or not. Fee-for-service versus essentially alternate or like a capitation-based model, or an hourly or daily rate if you worked in walk-in clinic, for example. So different ways of doing it. Most physicians, at least in the survey, this is like 770 physicians, not all of them, but most of them are okay with the remuneration system. If you look at the right-hand side, there's some interesting reasons why they might not be, and I'll come back to that. And here, so for family physicians, one rankling worry or concern is that we put a lot of our salary into our clinics because we're essentially small business people, right? But if the government were actually to help us, this would, and the surveys is we'd either be more likely to, set up shop as a GP, or we'd be more likely to continue. So very interesting feedback here. And again, in terms of doctors thinking, what should we negotiate with the province? The answer here was help with overhead for practices. So I'm just saying that this is what the doctors themselves are saying, or some of the doctors. Okay. Now this is interesting. There's a lot of discussion about IT, and you probably up to your eyeballs in IT and medical records. I just want to throw this out. Now at Dal, we're given like new platforms and everything. Oh, it's going to be so easy. And these platforms are great. We got like 20 platforms, and some of them we use once a year, and it takes me a day to figure out the friggin' platform, right? Well, doctors are pretty much in the same boat. And if you just look at 1, 2, 3, the fourth bar down, look at the amount of time that doctors are spending on administration, like ticking boxes, what category, what blah, blah, blah. And you look at the amount of time that they're spending now as opposed to 2018. There's a lot of time spending inputting the data. So you think we have to have more data systems? Who's providing the data, right? So you're going to get pushback. If you say to doctors, we want more data systems. Can you fill in these boxes, please? They're going, right? Stand back. Okay. Practice models. So again, feedback of physicians that, we'd be more interested in primary care if we had collaborative teams. And there's a lot of discussion on collaborative teams. What have you covered? What are collaborative teams? Yeah, so you had this slide before. So it's there are different ways. I mean, some people have said, well, there's 96 different collaborative care units in Nova Scotia. There's 96 different models of doing it. Essentially, there's 3 different models, and there's pros and cons for each one, right? So the government can pay GPs, and the GPs will pay the other healthcare professionals directly. There's problems with that if you're doing fee-for-service. Then if you have a practice nurse or if you have a psychologist, then the person actually has to be seen by the GP to get the fee-for-service payment. So it doesn't really save much money, even though it's more efficient. You can have a co-leadership model in which GPs and other healthcare professionals share the duties. You gotta hope people get along. And then there's a turnkey model where the government just puts everybody on salary, essentially, right? And again, I know I don't have much time, but this is pretty important. So in terms of where to go, keep in mind that physician autonomy is a Canadian model. And there's a lot of tension in what physicians should be expected to do. There was one slide a little bit back about why people didn't like the payment model, and they said that this would be fee-for-service. The payment model leaves me exposed to loss of income in event of illness or pandemic. Now, when Medicare was set up in Canada in the 1947 to 1965, in that time period, Canada was trying to set up the model according to the Beveridge model, and of course, as you probably know, the doctors in Saskatchewan went on strike, and they were absolutely upset by this. They would have none of it, and the compromise that was reached is that we would consider doctors to be essentially small business or entrepreneurs, right? And this is what we're left with. This was, as I said before, if you want to get a major policy, you might have to do compromise. This is our historical compromise, but it means that the landscape of what we have to work with is quite different. So I've seen other places where people say, oh, we should think about physicians as teachers, right? So that we say we put our kids into a school, we expect them to be accommodated. Well, I'm saying that's comparing, in the Canadian context, that's like comparing apples and refrigerators, right? It makes no sense, because teachers are salaried workers hired by the state. Doctors are small business operators. So I would say that the relevant comparator here is doctors and pastry chefs. So if you were, for example, to for whatever reason, believe that there are far too many donuts being made and not enough croissant, and you were to say to the pastry chefs, we want you to make more croissant, what would the pastry chef say to you, right? It'd be some variation of, you're not the boss of me, and you have to understand physicians to be operating on the same principles, right? They are autonomous, they are small business operators. Now, again, there's a tension. One of the downsides of a small business model is that you take some risk. When there's a downturn or your business is not doing well, you're a business person, you deal with it. But then you look at I wish I were paid by the state to have security, right? So there's always that tension there, yes.
But in fact, your previous slide said Doctors Nova Scotia is in fact a guild or a union. So what you really have is unionized independent businesses.
Yeah, essentially, yeah. And there's a tension there. And again, it's technically not a union, but not all doctors are happy with the decisions made by them. But it's their best force against the province, so they have to deal with that. So one of the big problems in the Canadian healthcare system across provinces is that there's a feeling that doctors don't have to take responsibility for the decisions that they make, right? They can order as many tests, or they can make as many referrals. They don't have to worry about the costs, right? Because they're small business operators. And so the question is, how can we integrate them into the healthcare system? There's other models. There's a UK model where it's essentially the state gives GP groups a big wad of money and then says to the GPs, okay, you look around at all the hospitals and see who offers you a better deal, and then go to that hospital, and that's how we make the hospitals compete. Right? So that's that model. There's a German model where regional associations of physicians take responsibility for supply and demand of healthcare services, which we don't have the physicians here doing. So that's one thing to think about. How it'd be great to get the physicians doing this kind of a task. How do you do it? Okay, I'm not going to deal with that or that. So another thing, again, is using other healthcare professionals. We've expanded the scopes of practice, and this happened especially during COVID, but it was happening historically. Nurse practitioners specifically. Nurse practitioners first in Canada trained at Dal from 1967, I believe, where they were used by doctors as auxiliary staff for work up north, and they were always expected to be supervised by doctors, and historically, gradually, they got more and more of a scope of practice. So now, I phoned up the College of Nurses, and I said, so what exactly is the scope of practice of a nurse practitioner in Nova Scotia? And they said, oh, you talk to Doctors Nova Scotia. So I talked to Doctors Nova Scotia. They said, oh, talk to the College of Physician Services. So I talked to College of Physician Services. And I said, so what is it that nurse practitioners can't do that GPs can do. And they said, I'll talk to the College of Nurses. So, essentially, if you look at it, especially in Nova Scotia, so the light green means that they're free to do it. And the green with lines mean that they can do some of it. But essentially, Nova Scotia, nurse practitioners have a huge scope of practice, right? And essentially, they can do a lot of what GPs can do, even though it's slightly more complicated than that, which is good. And it's also true for other healthcare providers, pharmacists and nurses and et cetera, et cetera, et cetera, psychologists, for example. And during COVID, the government wrote all these protocols that essentially expanded the scope of practice because we needed these. So anyway, we've got all these wonderful professions, and we have these different primary care models now because of this. But there's a huge problem. You probably have dealt with the trade-off between access and attachment, right? So all these small sort of de facto things that are set up provide good access, but people have no attachment. On the other hand, if you try to push people into practices, they might have a family doctor, they just can't see them, right? And the other problem that I want to point out is that according to the legislation, if you look at the legislation, if you're concerned about public health care as opposed to private health care, legislation in Nova Scotia defines insured services vis-a-vis the Canada Health Act as only those services provided by physicians. So if you are an optometrist or a dentist and you provide insured services in hospital, for example, you are considered to be a doctor for the purposes of the legislation. Only doctors can provide insured services. What this means is that now that we have all these other healthcare professionals like nurse practitioners who can essentially do whatever GPs do within limits, but again, the scope of practice matches a lot of GPs, I'd say. But they can provide insured services, but they are not considered insured services according to the Canada Health Act, which means that they can provide them privately, and they can also charge whatever they want for these services, which is why you get these new clinics coming up, like the Blue Nose clinics, which have all these private healthcare services run by nurse practitioners. So it's a good thing, but on the other hand, if the more you are dependent upon other healthcare professionals, you're looking at fueling the private healthcare market. Okay, so to end again, if you talk about policy making, it's all, if you want to get all these groups and interests involved in policy change, then the problem is that lasting policy where everybody's on board, is policy where people are willing and supportive and are brought into the process. But the problem is the more you bring all these interests into the process, the more you're going to have to compromise in what you achieve. So I'm going to leave you with that. And I look forward to any questions you might have.